Hello, everyone, and welcome to Tele-Health Education for your Health Awareness Campaign Talk Series, the FACFAS Initiative 2020-2021. This is an inaugural virtual public health education program, which is an academic community partnership among the International Community Initiative, the Maryland Rural Health Association, and the University of Maryland Eastern Shore School of Pharmacy and Health Professions. My pleasure to serve as your host again for this month's program today. A little bit about our organizers and partner of the FACFAS initiative. I would like to share with you the mission of ICI, the Maryland Rural Health Association, and UMES School of Pharmacy and Health Profession. In the interest of time, we invite you to visit the website of our respective organizer for more information about our mission and our programs. The mission of the FACFAS initiative is to promote healthy habits and raise awareness through an interprofessional collaboration and telehealth delivery of health information for the community. Our goal is to provide accurate health information, resources, and strategies based on selected health topics of the National Health Observance to promote health and prevent disease. This is a monthly 30-minute telehealth education episode brought to you by a variety of healthcare professionals. For more information and or to volunteer to help this initiative, please contact myself at the or Mrs. Rosen, the Executive Director of the Maryland Rural Health Association. As you recall, we shared with you the first and the second episode in September and October on depression, older adult, and COVID-19, as well as breast cancer awareness, respectively. This month, we bring to you diabetes awareness with Dr. Paul Sheitel. Did you know that November is Diabetes Awareness Month? We would like to bring you information on to be healthy and how to prevent diabetes. I would like to introduce Dr. Paul Sheitel to you. Dr. Sheitel is a retired co-founder of Baltimore City Podiatry Group, a former board member of Healthcare for the Homeless, and a current member of the American Diabetes Association Advisory Board. He also volunteered at the Baltimore station. Please help me welcome Dr. Sheitel.
Thank you for having me speak this evening. Have you ever heard someone say, I have a little sugar, or I can't have any candy because I am diabetic? Diabetes is a scary word to many people who have had a relative with this disease and have seen them undergo blindness and other complications. Many more have seen their relatives do quite well after having been diagnosed with this disease. Why the difference in expectations? The mindset of the patient may make this difference in outcomes. If they take charge of the disease by being compliant and knowledgeable, most do quite well and can live a relatively normal life. Those who let the disease take the driver's seat will struggle at every turn and probably lead a life filled with complications, disability, and possibly early death. Diabetes is a disease where self-management is critical in the treatment, along with communication with your healthcare team, which must include your endocrinologist or internist, nurse practitioner, physician's assistant, eye care specialist, optometrist, ophthalmologist, and retinal specialists, and podiatrist, possibly nephrologist. Any of the team that you decide to keep within your treatment regime needs to be consulted on a regular basis. What is diabetes? It's a problem with the body's fuel system. It is caused by the lack of insulin, a hormone made in the pancreas that is essential for getting energy from food into our cells. There are two kinds of diabetes: chronic condition that affects the way our body processes blood sugar or glucose. Type 1 usually starts in children, but can also start in adults when the pancreas stops making insulin. Type 2, the body either does not produce enough insulin or the body is resistant to the insulin. Some of the facts: 1 out of every 10 healthcare dollars is attributed to direct diabetes care. In seniors, almost 25% of the budget of Medicare is spent on diabetics and their complications. Increased from 2011, there are now 35% of the people in this country who are at risk. 84 million people may be at risk and have prediabetes. 80% of the people who are diabetic are overweight. 1 out of 3 Americans are projected to have diabetes by the year 2050. And 70% of women who had gestational diabetes during pregnancy will develop type 2 in their lifetime. The difference between the type 1 and type 2, only about 10% or 11% of the population of diabetics is type 1. The rest is type 2, which is usually a disease of lifestyle. The impact in Maryland is quite substantial. Approximately 623,000 people in Maryland are diabetic, 12.6%. Of these, about 156,000 are not even aware of it, which means their risk factors increase astronomically as they get older and how the disease progresses without their knowledge. In addition, 1.6 million people in Maryland, again, 36.9% of the population, have prediabetes. This is when your fasting blood sugar ranges between 100 milligrams per dilution and 125. After you've tested twice consecutively with 126 milligrams per dilution at a fasting blood test, you will be considered diabetic. And that's when much more expense is involved. Because the diabetic medical expense is approximately 2.3 times higher than those without diabetes. The total medical expenses of diagnosed and undiagnosed diabetes, pre and gestational diabetes, was estimated at $4.7 billion back in 2012, which is significantly higher now. The indirect costs from lost productivity, almost $2 billion. And these are statewide numbers. 2015, the estimate was $42,813,000 spent in diabetes-related research projects just here in Maryland. The Division of Diabetes Translation at the CDC spent $2.5 million on prevention and education programs. But the key is, if you're wondering if you have it or not, the best thing to do is to check your risk factors. Being overweight, having a parent or sibling with type 2 diabetes. If you don't exercise at least 3 times a week for 30 minutes, you're at risk. Having prediabetes, another big risk factor. History of gestational diabetes, or giving birth to a baby weighing more than 9 pounds. And once we compare the type 1 and 2, you can see the difference. Features: onset, sudden in type 1, gradual in type 2, and goes along from there. Ability to produce insulin in the type 1 is low or absent completely. But in type 2 diabetic, you may be producing normal amounts of insulin, but as you get older, it may be decreased, or the insulin sensitivity decreases, much more with people with abdominal obesity. Diabetes, again, once type 2, 1 in 3 adults are at risk for diabetes, and most importantly, don't know it. Let me show you what happens in a typical meal. You take in the food, the stomach converts the food to glucose. The glucose enters the bloodstream, and the pancreas produces the insulin. If it's effective, the glucose will be taken out of the bloodstream and into the cells to be used as energy. But if it's resistant or not enough insulin, the blood glucose would stay the same. So what happens if the blood glucose stays the same? Lots of things happen physiologically. Your skin ages quicker. You're basically 5 to 6 years older than a person without diabetes. And those are 2 main factors, insulin and glucose. Insulin is the key to unlocking the cell and letting the glucose get in. Without this, these glucose molecules stay in the bloodstream and start causing damage. Classical signs of untreated diabetes. These are people that don't know they have it, but start suffering from increased urination, increased thirst, and increased hunger. All of these 3 signs means you probably had diabetes for 2 to 5 years, because these The symptoms may develop much more rapidly in the type 1, while in the type 2, they're very gradual. And a lot of people that have diabetes don't know how good feeling it is ever going to happen. They felt so badly for the past few years, they're not sure how good it feels to be without these symptoms. In addition, blurry vision, headache, fatigue, slowly healing of cuts and itchy skin. All of these things start causing long-acting and prolonged disability. With high blood glucose, the glucose absorption in the lens of the eye alone leads to vision changes. Skin rashes develop. And the collective term for these skin problems are called diabetic dermatomes. Let's review for a minute. Diabetes testing. This is one of the critical factors to find out if you are adiabetic, if you're pre-diabetic. 100 to 125 impaired fasting glucose. 140 to 199 impaired glucose tolerance. That's after 2 hours of taking a sample of glucose and checking to see how your body metabolizes it. If the value after 2 hours is 200 or more, consider yourself diabetic. With an A1C test, that's a test that measures the average blood glucose for the past 2 to 3 months. 5.7 to 6.4 is at high risk. Once you've passed 6.4 to 6.5 and above, you're considered diabetic. And any random blood test you take should be less than 200. These are just diagnostic tests, which will always be a guideline. Once again, know these and know that it affects your entire body when your blood glucose is running high. And these are the ABCs of being diabetic. These are the things you must know when your doctor asks you, and it's very important in case you're not able to answer if you're unconscious. Keep a list of your medications. Keep a list of the names of the doctors that treat you and their phone numbers. Getting a blood alert tag on your wrist would be very useful. Why take the A1C test? Because it's one of the only ways you're going to find out if your current treatment is working. If it tells you your diabetes is progressing, then obviously you're going to change your treatment regime. You may have to just increase your activity. That's one of the good aspects of this, because the more activity you have, the better glucose control you will have. And it may actually improve the beta cell function and reduce insulin resistance. Most doctors will test this at least twice a year. One of the things which drives your diabetes is nutritional adherence. Consider dietary changes if you're diabetic, or even if you're not diabetic. Moving towards a more plant-based diet. Breads, grains, other starches need to be watched carefully, but getting off of more processed foods will help. Using whole grains. Keeping away from white bread, white potatoes, and fried foods will also make a very big difference. And culturally, whether your diet is based on corn or rice, these are very important factors to really keep an eye on. The impact of diabetes, it's the sixth leading cause of disease, of death in this country. Decreases life expectancy of middle-aged people by 5 to 10 years. 2 to 4 times greater risk of death from heart disease, strokes, and gangrene. Compounding factors include duration of the disease, glycemic control, hypertension, smoking, dyslipidemia, decreased activity, and obesity. It's the leading cause of blindness in 25 to 74-year-olds. It is the leading cause of non-traumatic amputations. And over 70% of these amputations are avoidable with proper care and inspection. And it's also responsible for 25 to 30% of all new dialysis patients. How do you know when you're getting into big trouble? Low blood sugar, you'll be confused, anxious, shaky, sweating, dryness of tingling in the mouth, blurred vision, and heart palpitations. If your blood sugar is running highly out of control, increased urination and increased thirst, you're going to be dehydrated, blurred vision, fatigue, headache, and sometimes a sweet-smelling breath, indicating that you are burning ketones, which is a very dangerous condition. I just want to show you also the effects on all of the organs. All of these will be suffered from high levels of glucose over a long period of time. Keeping your blood glucose at a level less than 150 or an A1C of less than 7 is optimum. Complications can include numbness, tingling, pain, altered pain sensation, which can lead to damage to the skin. What you're losing is your protective sensation. Once that is lost, you're more prone to developing diabetic foot ulcers, 15 times more likely to develop an amputation and gangrene after having multiple foot ulcers. Additionally, proximal diabetic neuropathy, which means that the neuropathy extends upwards on your leg. And it can actually start as a numbness or tingling in the foot. It can also increase to intractable pain. And the last stage of the neuropathy would be total anesthesia, where you can't feel pain at all, and you're not even sure where the feet are in relation to your body. You stagger around, and many times are confused for someone that's intoxicated. Microvascular complications mean disease of the small vessels. These are the vessels that damage your eyes, kidneys, and nerves. Damage to the eyes, known as diabetic retinopathy. And it's a reason to see an eye doctor for a dilated retinal exam at least 1 to 2 times a year. Retinal specialists are people that can check into the eye and see if there's damage. And this, not doing this can really lead to gradual vision loss and blindness. Same with damage to the kidneys, known as diabetic nephropathy. When going for your routine physical exams, make sure you have urine test that checks your microscopic albumin. All of these, high protein in the urine indicates possible damage to the kidneys. And once you have chronic kidney disease, the end stage of that is dialysis or kidney transplantation. Diabetes is the most common cause for amputation, blindness, and other problems which cause major debilities. Macrovascular, again, these are the larger vessels, the coronary artery vessels and peripheral vascular disease. Complications, again, develop usually after 10 to 20 years of having type 2 diabetes. Diabetes and podiatry. Foot inspection is critical. You should have a regular podiatrist who can start you at a baseline when you first find out you're diabetic. Measure your pulses, how the circulation is, how the nervous system is functioning. Changes in color of the skin, swelling in the foot or ankle. Numbness anywhere in the foot, leg and ankle pain. Open and slow healing sores. Ingrowing toenails. Chronic fungus and other infections. Bleeding corns and calluses, blisters and bunions. Cracks and extreme dryness. All of those things can lead to chronic problems and debility. Don't forget, when you're having these problems on the lower extremity, walking and wearing a shoe may become impossible. And that contributes to your decreased quality of life. Controlling your diabetes involves controlling your blood sugar and your diet and increasing your movement, exercise. 3 critical factors to determining how successful your treatment will be. And all of this, again, is up to you. If you decide to take charge of diabetes, you can probably handle it. If you let the disease take over you, it will win. Prevention all starts with a better lifestyle, eating healthier, being active, taking your medicine as directed, generally being compliant, taking care of your body. Check your feet to make sure there are no nerve damage or interruption of blood flow. Take care of teeth. Periodontal disease, again, is extremely disabling and expensive. Control blood pressure and high blood pressure, whether it's high or low. No smoking. Check in with your doctor at least once a month. Have your blood sugar checked along with weight, blood pressure, and feelings. Check blood sugar levels daily by using your home glucometer. The common treatments of diabetes, we've all known about that. There's no shortage of medication to treat the diabetic. There's a shortage of patients who are compliant using these as directed. Because if used directly under the orders of your physician, the medications, diet and exercise, and testing will get you through this problem. Good outcomes are definitely possible with proper control. Here's a 75-year-old obese male weighing 240 pounds that has type 2 diabetes. His average glucose, 9.1, which means it's well over 200. 60 units of long-acting insulin and 10 units of short-acting insulin were given after meals. Weeks later, major weight loss, increased his exercise, walking 30 minutes 3 times a week, and got his blood glucose down to 95 and 105. That range is very healthy for him. A1C is 6.9. He's under the threshold for developing major complications. No longer needs long-acting or short-acting insulin. Once again, I'd like to thank you for letting me give you some of the major points of finding out if you have diabetes and treating it. Once again, thank you very much.
Thank you, Dr. Sheitel, for a very informative presentation. For the audience, if you have any comment or suggestion for our future program, please send us an email at outreach@icius.org. As we conclude the program, I would like to remind you to stay tuned for our next month's program in December. The topic is determined. Until then, take care and have a good evening.